Page number 3. Cystocytes, or otherwise called helmet cells, are fragmented RBCs. So RBCs, if fragmented, are called helmet cells. They occur secondary to mechanical trauma from microcytic and microangiopathic hemolytic anemia. So microangiopathy means small blood vessels. So in the small blood vessel there occurs hemolytic anemia, and so hemolytic anemia means hemolysis RBC rupture, thus resulting in helmet cells or prosthetic cardiac valves, where the mechanically RBCs strike against the valves, thus and are broken down. Therefore, helmet cells are formed. Intravascular hemolytic anemia are characterized by decreased serum haptoglobin. So haptoglobin then binds to the remnants of the broken parts. So haptoglobin binds to the broken RBCs, small segments, uh, especially to the iron in the hemolytic RBCs. Thus, the amount of haptoglobin in the blood now decreases, as well as because of the hemolysis, the cellular LDS and bilirubin increase in the blood. So indirect hemoglobin or unconjugated bilirubin and LDS, lactic dehydrogenase, which is present in the cells of RBCs that are released in the blood, thus increasing the LDS level. So SBF is a predominant hemoglobin type in the second and third trimester of pregnancy. So in the baby, SBF fetal hemoglobin is the predominant hemoglobin type in the second and third trimester of pregnancy and during the first few months after birth. So SBF so fetal hemoglobin contains 2 alpha and 2 gamma protein subunits. So alpha 2, gamma 2, and a high affinity for oxygen, thus causing left shift in the hemoglobin oxygen dissociation curve, which facilitates oxygen transport across the placenta to the fetus. So from the placenta to the fetus, oxygenated blood can easily flow, and SBA, so alpha 2 beta 2, is the major hemoglobin in adults. So there are SBA, SBA2, which contains alpha 2 and delta 2, and in SBF there is alpha 2, gamma 2. As again, I'll talk about just hydroxyurea. So hydroxyurea is one of the drugs which converts the SBA, the alpha 2 delta 2, into SBF. So alpha 2 gamma 2. This is used as a treatment strategy in sickle cell disease. Amyloid light chain amyloidosis is associated with multiple myeloma and other monoclonal plasma cell dyscrasias due to the deposition of insoluble immunoglobulin light chain fibrils in major organs. So amyloid light chain amyloidosis is associated with multiple myeloma. So in the multiple myeloma, there is some indigested proteins, plasma proteins, which are amyloid light chains. So amyloid light chains, they are not digested by the body, hence they result in amyloidosis and other monoclonal plasma cell dyscrasia. So dyscrasia can also occur due to the deposition of insoluble immunoglobulin light chain fibrils in major organs. So they, in multiple myeloma, the fibrils, so in amyloidosis, there is the there is the formation of insoluble immunoglobulin deposits, including in multiple myeloma. There is excessive proliferation of plasma cells. This is one of the plasma cell disorders. So those plasma cells are insoluble and form insoluble immunoglobulin light chain fibrils, which deposit in major organs like kidneys, heart, and neurological systems. A bone marrow sample with more than 10% plasma cells is strongly suggestive of multiple myeloma. So multiple myeloma can be treated by more than 10% plasma cells. Okay. Now, a bone marrow sample with more than 10% plasma cell. So 10% of more than 10% of plasma cells inside the bone marrow is deductive for multiple myeloma. Folic acid deficiency anemia commonly occurs in alcoholism. So when alcoholism can cause folic acid deficiency, so thus causing macrocytosis, it is a megaloblastic anemia that develop within weeks. So within weeks, megaloblastic anemia develops when alcohol is taken. So in PBS, because it is megaloblastic anemia, there is macrocyte, overocytes, and neutrophils with hypersegmented nuclei. So more than 5 segments in neutrophils can occur in folic acid deficiency anemia because of alcoholism. So if there is a picture or clinical vignette with any case of alcoholism, then folic acid deficiency is a common finding which results in macrocytosis. So alcoholism and macrocytosis are also related. SLE is an autoimmune disorder that occurs mostly in women. Heme abnormalities are common. Autoantibodies against blood cells, that is blood cell antigen HS2, can cause pancytopenia. So blood cell antigens like HS2. So SLE and HS2. So I'll just briefly talk about HS. you know, so HS, what is the meaning of HS2? Mm, so it's not hereditary suppurativa. It is. I'm not sure. So yes, I think hereditary spherocytosis. So yeah, hereditary spherocytosis too. Okay, let's talk. And can cause pancytopenia. So in sickle cell anemia is also one of the causes of pancytopenia. Anemia, thrombocytopenia, leukopenia can occur because of decrease in all the three blood cell lineages. In contrast, lupus nephritis is caused by IC deposition, IC deposition, so immune complex deposition, that is HS3 in the glomeruli. So HS2 and HS3. So what is SS2 and SS2, SS3? I'm not very sure. So yeah, hypersensitivity. So it is hypersensitivity too. So sickle cell anemia can cause, SLE is more associated with hypersensitivity type 2, and because it is immune complex deposition, it is hypersensitivity type 3. So hypersensitivity SS results from, so it is now, this SS is now hereditary spherocytosis is from red cell cytoskeleton abnormalities, most commonly spectrin and ankyrin. Ankyrin spectrin protein anchors the cell red cell membrane, but because of defects in the spectrin and ankyrin, then hereditary spherocytosis can occur. Hemolytic anemia, jaundice, and splenomegaly are classical symptoms. So hemolytic anemia, jaundice, and splenomegaly. So in hereditary spherocytosis means bursting of RBCs. This causing decreased RBCs. That is anemia. Jaundice and splenomegaly are classic, manifestations. Spherocytosis are also seen in the peripheral PBS. Yeah, in spherocytosis again, MCHC means MCHC mean corpuscular concentration is increased. So in spherocytosis, MCHC is increased due to mild dehydration of the RBC. Spherocytosis, in spherocytosis, there is a relative dehydration of the RBCs. There is some loss of, sodium from the RBCs, thus causing there is some sort of dehydration. Markers of hemolysis are often evident, and by increased LDH, so there is more destruction of RBCs. Thus, bone marrow tries to produce more reticulocytes, and reticulocytes increase, causing reticulocytosis, and more the broken RBCs bind with haptoglobin. Thus, the total amount of haptoglobin in the blood reduces. Okay, HS means hereditary spherocytosis. Result from hereditary cytokine abnormalities, most commonly the protein spectrin and ankyrin, increase osmotic fragility. So because the RBCs are now round, there is more fragility of the red cells. On acidified glycerol lysis testing. So acidified glycerol lysis testing. So those RBCs, when kept in glycerol, which has some acid in it, then those such type of cells lies, thus confirming the diagnosis. Hemolytic anemia, jaundice, splenomegaly, classical manifestations. Now complications include pigmented. So because there is increased amount of indirect bilirubin, then pigmented gallstones. The chances of pigmented gallstones rise, and aplastic crisis from parvovirus B19 infection, which is a single-stranded, non-enveloped DNA virus infection. It's common. Okay, so hydroxyurea increases SPF synthesis by an unknown mechanism. HCU is reserved for patients with frequent pain crisis when there is more, there is acute chest syndrome, priapism. When there is more, complaints of pain by the patient, then hydroxyurea may be considered in case of sickle cell disease. Gardos channel blockers. So Gardos channel. So there is something called Gardos channel. So these channels, when blocked, hinder the efflux of potassium. So potassium it stays inside the cell, and water from the cells. So potassium and water stays inside the cells, thus preventing dehydration of RBCs and decreases the polymerization of SBS. So in sickle cell disease, one of the most key component in the management strategy is giving ensuring adequate hydration. So when hydration is ensured, then water stays inside the cell, and there is dehydration of erythrocyte is decreased. Thus, polymerization of SBS, sickle cell polymerization, is reduced. So hydration is one of the key components of management of SCD. So hemolytic anemia is a possible adverse effect of dapsone. So dapsone is one of the drugs which causes hemolytic anemia, and is most significant in patients deficient for GCPD. So in GCPD deficiency patients, dapsone is more likely to cause hemolytic anemia. GCPD deficiency anemia is characterized by episodes of hemolytic anemia precipitated by oxidative stress. So in GCPD deficiency, oxidative stress is cannot be cooperated or withstood more by the cell. Thus, drugs infection which increase the chance of oxidative stress causes you know RBCs to rupture, and thus those you know oxidative stress or oxidative ROS or reactive oxygen species stays or stents the RBCs and forming Heinz bodies. So Heinz bodies are classical manifestations of this anemia and shows bite cells. So bite cells are also formed. GCPD deficiency has an X-linked recessive inheritance. So GCPD deficiency is one of the examples of X-linked recessive disorders. X-linked recessive disorders. Hereditary spherocytosis follows an autosomal dominant pattern. So GCPD is X-linked recessive. G6PD. There are four letters. So GCPD is four letter means the distant alphabet is more closer. So closer. So X-linked recessive disorder, inheritance, X-linked dominant disorders are very few. Hereditary spherocytosis is an autosomal dominant because H is closer towards, the shorter word is closer towards the earlier letters in the alphabets. Okay, all right. Patients with sickle cell trait are typically asymptomatic and have relative protection from malaria caused by plasmodium falciparum. So, sickle cell trait. So, our plasmodium falciparum parasites goes inside RBCs. The measures of the parasite goes into the RBC and bursts the RBCs, and due to which fever occurs. But the Plasmodium falciparum, when enters the RBCs, the weak RBCs, or like in sickle cell disease, sickle cell trait, cannot harbor much of Plasmodium falciparum parasites and thus burst when even a small number of measles infect those RBCs, and thus providing a relative protection from malaria. These patients usually have normal hemoglobin, so the hemoglobin is normal, reticulocyte count is normal because there is no breakage or rupture of RBCs. Hemoglobin is normal, reticulocyte is normal, and RBC values are normal. Life expectancy is the same as that of the genetic population. So, general population. So, similar to general population, lifespan is not affected in case of SCT with Plasmodium falciparum. Patients with sickle cell disease. So, sickle cell disease perhaps it's one of the most important topics in step 1 in the hematology and oncology topic. Patients with sickle cell disease become functionally splenic within a few years of life due to repeated microinfarction of the splenic vascular beds. So sickle cell form some sort of clot and thus decreasing the blood supply of the spleen much frequently, and thus causing atrophy and some fibrosis of the spleen, and autosplenectomy can occur. This dramatic, and spleen is most responsible for decrease the amount of encapsulated organisms. So encapsulated organism now thrives because of absence of sickle spleen, like Staphylococcus pneumoniae, patient pneumonia, as well as Neisseria meningitis and Staphylococcus pneumoniae and Haemophilus influenza. So these three encapsulated organisms are frequently associated with sickle cell disease. There is also a risk for bacterial infection, mostly Salmonella osteomyelitis. So Salmonella osteomyelitis is one of the the cause of osteomyelitis is mostly Staph aureus, but in sickle cell disease, Salmonella is one of the most commonly implicated organisms. Okay, the triad of HA, so hemolytic anemia, hypercoagulability, and pancytopenia. So PN is also one of the very important topics. So in PN's paroxysmal nocturnal hemoglobinuria. So paroxysmal means in burst, nocturnal means at night, hemoglobinuria. So hemoglobin is secreted in the urine at night. So hemoglobin means dark color urine is passed at night, because dark color urine is formed because of hemolytic anemia. So hemolytic anemia forms in that hemoglobin and goes into blood, so oxidation occurs, and there is black colored urine. Hypercoagulability. So hypercoagulability occurs because of in hemoglobinuria. There is hemoglobinuria, so there is more increased amount of hemoglobin. So hemoglobin is increasing because of hemolytic anemia, and hypercoagulability is one of the very commonly associated symptoms in PNH. And pancytopenia. So hemoglobinuria, there is decrease in this of all the three blood cell precursors, thus causing pancytopenia. PNH is from an acquired mutation in the PIGA gene. So PIGA gene, there is something called PIGA gene. So GPI anchor. So there is something called GPI anchor and a deficiency of CD55 and CD59 complement inhibiting protein. So see, in PLS, so paroxysmal nocturnal hemoglobinuria. So in paroxysmal nocturnal hemoglobinuria, there is undue activation of the complement proteins. Why? Because complement proteins are actually inhibited for its so the activation of complement proteins is inhibited by a normal platelet. How? The normal platelet, or let's say a normal platelet has something called CD55 and CD59 in its surface. So CD59, 55, 59 is anchored in the cell surface by something called GPI anchor, and which is coded by a PA gene called PA gene. So PA gene codes an anchor protein which is called GPI anchor, which holds CD55 and CD59, which generally inhibit the complement proteins. But at night, when there is relative anoxia or hypoxic state, then these proteins cannot these CD55 and CD59 cannot inhibit the complement proteins. Thus, there is undue activation of complement proteins. Those undue activated complement proteins destruct or destroys the RBCs and thus causing hematuria at night. Okay, now building from tooth extraction and history of hemarthrosis associated with hemophilia. So hemophilia, there is factor 7 and 8 and 9 deficiency. So in factor 8 and 9 deficiency, there is no conversion of prothrombin to thrombin. So prothrombin does not form thrombin. And thrombin is essential for thrombus formation. So the addition of thrombin to the blood with patient hemophilia results in clotting. So in hemophilia there is no clotting factor number 8, no clotting factor number 9. So because there is no any intrinsic pathway. So no, because of the absence of any intrinsic pathway, prothrombin cannot convert to thrombin. So when thrombin is given, so in hemophilia there is less thrombin. So when thrombin is given, then thrombin results in clotting, because thrombin is a clotting agent. Therefore, it results in clotting, especially in hemophilia because there is no thrombin. So when thrombin is given, then clotting occurs. Now, patients with symptoms of von Willebrand disease can be treated with desmopressin. So desmopressin. What is desmopressin? Desmopressin is a synthetic ADS analog that has no vasoconstrictive effect. So desmopressin. Desmo means blood vessel. Desmopressin means blood vessel compression. So there is no constriction of blood vessels even if desmopressin is given in patients with von Willebrand disease. So von Willebrand disease is generally treated by a synthetic ADS analog which is called desmopressin, but it has no blood constricting effect. So it releases some of the endothelial stored BWF, which is functional now, because in BWD, that is von Willebrand disease, there is non-functional non-functional endothelial cell storage collagens. So von Willebrand factor binds to platelet by a GP1B receptor, but in von Willebrand disease there is no von Willebrand factor, or the von Willebrand factor that is present in the endothelium, within the endothelium, is non-functional. So when von Willebrand factor is so this was given, it increases the BWF and factor 8 released from the endothelial cell storage through indirect mechanism. So factor 8 is also activated, and one Willebrand factor is also released. Thus, it is used prophylactic prior to procedures of treating the minor bleeding. So it is used to treat minor bleeding. Mycoplasma pneumoniae binds an oligosaccharide on the. So mycoplasma pneumoniae means, of course, kind of mycoplasma is an atypical organism. It causes pneumonia. So yeah, it binds an oligosaccharide on the respiratory epithelium, which is present on erythrocytes. So in the erythrocytes or RBCs also. So in the respiratory epithelium, there is an oligosaccharide. So oligosaccharide is present in the respiratory epithelium, where mycoplasma pneumoniae binds. So it is also present. So that similar oligosaccharide is present in the RBCs as well, leading to generation of cross-reacting IgM antibodies. So cross-reacting IgM antibodies are cold agglutinins form. So when mycoplasma pneumonia, to destroy mycoplasma pneumonia, which binds to the oligosaccharide in the respiratory epithelium, our body produces IgM antibodies, which despite only attacking which instead of just attacking the respiratory epithelial, mycoplasma pneumoniae also attacks the erythrocytes. Thus, some cold agglutinins or IgM antibodies form. Now, patients with mycoplasma pneumoniae infection, they often develop mild transient hemolytic anemia that resolves as IgM antibody titer declines 6 to 8 weeks after infection begins. So these cold agglutinins, cold agglutinins, IgM antibodies generally fade after some 6 to 8 weeks, and IgG antibody is now formed. So IgM antibodies usually used to attack the respiratory epithelial microantimony, but which mistook erythrocytes, oligosaccharides present in the erythrocyte and caused hemolytic anemia, but it now decreases 6 to 8 weeks after infection begins. So now the next point is polycystic kidney disease causes hemolytic anemia. So how does polycystic kidney disease, there is more multiple cysts in the kidney, causes hemolytic anemia? So it causes hemolytic anemia due to failure of glycolysis. So glycolysis failure occurs and resulting failure to generate sufficient ATP. So I think, what is PKD? So there is no glycolysis, so there is insufficient ATP. So insufficient ATP cannot cause maintain the normal sodium potassium ATPase pump in the RBCs. In this case, splenic hyperplasia results from increased work of the splenic parenchyma, so which must remove these deformed RBCs from the circulations. PKD, so polycystic kidney disease. PKD, I'm not sure what PKD is. PKD is, let me just search PKD and hemolytic anemia. So PKD is not polycystic kidney disease. Sorry, it is pyruvate kinase deficiency. It is an there is a deficiency in enzyme pyruvate kinase, so which is used by RBCs. So without this enzyme, RBCs break down very easily, so causing hemolytic anemia. So in pyruvate kinase deficiency, there is failure of glycolysis. So glycolysis failure occurs and there is no ATP, sodium potassium ATPase does not function, thus RBCs destroy themselves and hemolytic anemia can occur. In this case, splenic hyperplasia. So and how does splenic hyperplasia occur? So now, because of deformed RBC structure, spleen has to work more, and splenic hyperplasia occurs. Which more, splenic hyperplasia occurs. Splenic parenchyma is increased. Now let's talk about 2,3-BPZ. So 2,3-BPZ decreases hemoglobin affinity for oxygen, thus causing a right shift in the oxygen hemoglobin dissociation curve. Therefore, in presence of decreased blood oxygen concentration, higher. So if there is decreased blood oxygen concentration, so when there is decreased amount of blood oxygen concentration, higher 2,3-BPZ levels with the erythrocytes enable increased oxygen delivery in the peripheral tissues. So 2,3-DPG. So 2,3-DPG causes right shift, means more release of if there is less concentration of oxygen in the blood, then higher 2,3-DPG within the RBCs causes more release of oxygen in the peripheral tissues, thus causing right shift. 2,3-BPZ is produced from 1,3-BPZ by the enzyme BPZ mutase. BPZ mutase 1,3-BPZ converts to 2,3-BPZ. 2,3-BPZ, when increase in along with decrease in pH, so decrease in pH and increase in temperature results in right shift to the curve. Right shift to the curve means more release of oxygen in the peripheral tissues. This reaction bypass an ATP generating step in the glycolysis, causing no negative ATP. So there is no generation of ATP. So 1,3-BPZ to 2,3-BPZ, there is no any ATP generation when this reaction occurs. Now the PPP. So that is pentose phosphate pump. So PPP consists of an oxidative branch or irreversible branch and a non-oxidative irreversible branch. So the pyruvate HMP, or let's say hexose monophosphate salt, consists of, there is hexose monophosphate pyruvate phosphate. So pyruvate pentose phosphate pump. So pentose means pentose sugar, R5P, and phosphate means hexose means fructose, fructose 6 phosphate. So in there is an oxidative branch, and oxidative branch, which is when oxygen is kept, there is irreversible stages. So oxidative stage branch is irreversible, whereas non-oxidative branch is reversible, and is can function independently based on the cellular requirements. Transketolase is an enzyme of the non-oxidative branch, is responsible in part for the interconversion of R5P, so ribose 5 phosphate, and fructose 6 phosphate glycolytic intermediate. So ribose 5 phosphate helps in DNA synthesis, and fructose 6 phosphate is a part of glycolysis cycle. So PPP and glycolytic cycle are also related. How? because it's there is a in the non-oxidative branch of the pentose phosphate fund of a pathway. There is a generation of fructose phosphate, which is produces phosphate, which is an intermediate for glycolysis. Okay, this PD is a rate limiting enzyme of the pentose phosphate pathway. This PD deficiency is common axillary receptor and receptor disorder, resulting in episodes of hemolytic anemia during times of increased oxidative stress. So, increased oxidative stress, for example, use of antimalarials, sulfonamides, infections. So, in these stresses, oxidative stresses, then this is PD. There is more generation, excessive generation of free radical. So, free radical destroys the RBCs causing hemolytic anemia. Okay, this will deficiency causes hemolytic anemia and jaundice. Secondary to increase oxidative stress due to lack of NADPS. So the NADPS is the reducing substrate. So because of no decrease synthesis of NADPS, then there's more increased oxidative stress. Glutathione reductase deficiency has a similar clinical consequence as its absence results in an inability to utilize NADPS to reduce glutathione. So, there is something like, to decrease the oxidative stress in the blood, reduced glutathione is necessary. To form reduced glutathione, NADPS is necessary. Because there is lack of NADPS, reduced glutathione is decreased. Decreased amount of reduced glutathione cannot decrease the oxidative, you know, cannot decrease the free radicals in the blood. So, superoxidation and some various free radicals are formed and causing hemolytic anemia. So, now next point is TNF alpha is thought to mediate PNP catches in humans by suppressing appetite. So TNF alpha, PNP cachexia. So what is PNP cachexia and cancer cachexia? So TNF alpha and cancer cachexia. Okay. So because of TNF alpha, there is weight loss. So weight loss. How there is weight loss? Means there is some decrease in appetite and basal metabolic is increased. So basal metabolic is increased and appetite is decreased. Therefore, there is weight loss in humans after cancer, because cancer cells secrete TNF alpha. There is cachexia. Okay. Now vitamin K deficiency relates an impaired clotting factor for carboxylation. Vitamin K is necessary for carboxylation, but carboxylation decreases in vitamin K deficiency. Thus, 2719 clotting factors are not formed. Newborns are at high risk for vitamin K deficiency due to poor transplacental transfer of vitamin K and low content breast milk. So baby breast milk has low vitamin K, and transplacental vitamin K transmission is also very less. And all newborns should receive vitamin K prophylaxis to prevent breeding complication. Okay, PBS is characterized by, so this Plummer Benson syndrome is characterized by dysphagia because of esophageal wave formation, iron deficiency anemia, decreased esophageal wave formation, and iron deficiency anemia causes dysphagia. So dysphagia is a result of esophageal wave formation. Findings associated with iron deficiency also include sponge-shaped nails, and there is some test called a bead test. A bead is kept in the nail and is looked whether or not it falls. In normal nail it falls, but in polynasia sponge-shaped nails it stays. And the red shiny tongue, so there is shiny tongue as well, beefy red tongue. Most symptoms resolve following iron supplementation. So iron deficiency is the root cause for PBS. So supplementation decreases PBS. Now, so heparin is commonly used for the prevention of DVT in non-ambulatory patients or those undergoing elective surgery, especially hip and knee surgery. Heparin increases the effect of naturally occurring anticoagulant antithrombin 3. So heparin increases the effect of naturally occurring anticoagulant antithrombin 3. So and normal anticoagulant in the blood is antithrombin 3. So heparin increases the amount of antithrombin 3. Therefore, thrombin is decreased. So thrombin means thrombus. Thrombus is deep vein thrombosis. So in deep vein thrombosis patients, and heparin is used because it increases the amount of antithrombin 3. Easy peasy, lemon squeezy. Okay.